talk, so I hope it makes sense, and I'll be interested in your comments and thoughts about how to present this material better, assuming that it's worth presenting at all. So here are my slides. I hope. You're right, yeah, that might have worked, and I'm just going to maximize that. Okay, so my title is Improving the Impact of AI in Practice, and that's a big claim. And it really builds on a talk that Niels gave recently about the problems of AI getting into practice and the points that Enrique Coira has made around the last mile. And my claim is that we should go beyond validation studies and randomized trials. And there's something that we should do in between, and that's what I call user impact studies, psychological experiments, if you like. And there's a short list of my current affiliations, including I'm very proud of my membership of the Cotswold Sculptors Association and the Association of Contemporary Jewelers, but that's another topic. So I think we probably all know that AI systems are not making it into clinical use. So very few are being used in practice. And yes, validation of performance is universally conducted, not always very well, and it is essential, but it's insufficient. Randomized trials are also essential, but they are risky, and we'll talk about some of the risks in a minute. But I believe that there's a missing stage between validation and doing randomized trials, and it's psychological or so-called intervention modeling experiments. And I'll explain what those are and give some examples of IMEs that we have conducted and what we learned from them. They're not easy, they're not completely straightforward to conduct, otherwise everyone would be doing them already. But I believe that we can and should be doing them more often. And then there's a summary and conclusions. So the hard truth, and this is based on what Niels was saying in his lecture recently, and on Enrico's paper, less than 10% of decision support tools, AI tools, are studied against a gold standard or outside the lab in which they were developed. And less than 10% have an impact on clinical practice. And there's, Niels, you pointed me towards the global clinical AI dashboard, which is just wonderful. And the figures there's huge numbers that have been tracked, but very few are actually in use in practice. And some tools don't even move beyond a kind of limited internal validation to look at their accuracy on data sets from outside the development side. There are some problems with model validation studies, and just quickly, I've got a table here really outlining the various validation methods. So internal validation, the aim is to evaluate the model performance the same data set used for the development process. And there are three main techniques: split sample, cross-validation, and bootstrapping. I'm sure you're familiar with all of those. And they are in the increasing order of rigor. But even more rigorous is external validation, which you evaluate model performance on a new data set that's not been used in any way in the model development, and is preferably from a new site or set of locations. So that's model validation. We know that a lot of the model validation studies are really quite biased, and this is a systematic review on medical imaging algorithms a few years ago now. Only 9 studies were prospective, just 6 were tested in a real world setting. The median number of experts that we used to assess the gold standards was only 4, etc. High overall risk of bias and poor adherence to the reporting guidelines, the tripod guidelines. And there was also claims in the abstracts of these studies in 3/4 that the performance of the AI was at least comparable or better than the clinicians, but only a small number, a third basically, stated that further studies or trials were required. And that's the risk of bias diagram showing that there was high risk of bias, or it was unclear around the participants, the outcomes, but particularly around the analysis and overall high risk of bias. Low risk of bias really only applied about 22% of those studies. So, however, that's thinking of validation as being an end in itself, and that we need to do those studies better. But there are some false assumptions if you just think about validation as being the most important study. First of all, the assumption is that high-performing algorithms will replace human decision makers. Well, that's not the case. Particularly in high-risk settings, AI will always be used to support humans, at least until the clinical culture status changes and AI reliability is really well established, maybe 5, 10, 15 years yet. So AI is going to be used to support human decisions, not to take them. For example, mammogram interpretation or estimating the risk of CVD. So the implications of that are that users need to incorporate the output of the AI, whatever it is, textual advice, a figure for risk, percentage risk, say, or a segmented outline on some kind of medical image, into their decisions. And that means they need to be able to find that output, understand it, and trust it. And that means that developers must present the output in a format that users can locate, find acceptable, trustworthy, and even persuasive so that it influences their decision making. And it's very hard to predict whether users will be able to do that. It's not just a simple matter of saying, well, write it this way or put your percentage figure in that format and people will be able to do all that. It's not obvious. We don't have enough research on what advice users find acceptable and persuasive. So what we have is the kind of standard AI evaluation pipeline. You develop your algorithms, you validate it, and you select the best. Often there's a series of algorithms that are developed. You select the best one, the highest ROC area, etc. You then obtain CE marking, etc., get it past the regulatory hurdles, and carry out a randomized trial and then promote to the market. Sometimes people don't carry out an RCT and promote to the market just on validation results, and that to me feels quite risky, particularly in high risk settings. But there's an assumption that once you've validated, go on to the RCT. One point, though, is why should we bother with RCTs and impact evaluation? As some computer scientists find it quite perplexing. Why should we bother with this? We know it's a good algorithm. The problem is that, particularly in healthcare, it's just too messy and complex to predict which technology will actually work. Even well-designed AI systems can fail. And certainly the first trial that I did way back in 1986, published at MedInfo 89, it was a failed diagnostic decision support system called ACORN. And if you look at systematic reviews such as that by Garg in JAMA 2005, a high proportion of randomized trials of diagnostic decision support failed. I think the figure was something like 60 or 70%. So only 20 or 30% of diagnostic decision support systems led to a change in clinical practice, which was their criteria for success or failure, compared to something like 80% of e-prescribing decision support systems were effective, and similarly for preventive care reminders were often effective. So there's something about diagnostic decision support that is often unsuccessful. You're probably familiar with Ross Koppel's write-up of the Integrated Medicines Management System, which included AI for a children's hospital in America, and it's likely that it caused some deaths of children. And we did a study on using MSN Messenger to facilitate nurse triage for NHS Direct for people who were deaf. And that again failed. You'd think that that would work really well. It didn't. The nurses were unable to build rapport. That's not actually AI, but there are failed studies out there. So we need to do those studies to find out whether these systems work or not. However, there are risks of moving straight from validation to RCT. First of all, RCTs are expensive. They take time to set up and run and analyze. And there are delays in getting clearance, all the ethical permissions, clinical trials, regulatory, but just simply connecting your AI algorithm to the electronic patient record and integrating it with the interface that the clinicians are using. That's going to be a slow and painful process. But even then, even if you do that, there's uncertainty about whether the AI will actually be used or whether the output will be understood and acted on. And this is an example of a trial which we did wasn't of AI, it was actually of BJ Fogg's persuasive technology, which is a checklist of things that make websites persuasive. This was actually a really quick and easy trial to do. So there are ways of running trials fast, particularly if you can carry out the intervention and measure the outcome online. So what we did, we were interested in whether we could turn. BJ Fogg developed his guidelines, his checklist of what makes a website effective for e-commerce sites, and we thought, well, maybe we can turn swords to plowshares and use this for public health. And the decision that we decided to work on was whether we could persuade university students to sign up for the NHS organ donation register. So we designed two different versions of a website which had all of the same content, but the format was different and it differed in the key ways that BJ Fogg says are important. So that was the control website with a generic logo, no obvious affiliation. It did have some subtle adverts down the side, as you'll see. And then this was the most persuasive version. Rather than trying out one of these persuasive features, I persuaded my colleagues that we should do a kind of all or nothing trial. Let's just try all of them against none of them. And if we don't find a difference, well, that kind of calls BJ Fogg's theory into question, at least in healthcare. So you can see that there's a URL which included an identity, a university logo. There was no advertising. There were references, contact details for us, a privacy statement. All articles were dated, and the site was certified with W3C and Health on the Net. You can tell this is fairly historical. I think it was about 2010 or 12 we did this. And amazingly, when we did this trial, we were able to recruit 900 student participants in 5 days. In fact, we slightly overshot. Our sample size calculations indicated we only need about 800. We were overshot. We didn't close it too fast enough. And interesting, there was no difference in the NHS organ register sign-up rates. It was 38%, very high in both groups. So rather against what Fogg had said. Now, of course, it's rather a momentous decision. It's not quite like buying a book or a CD on Amazon. Deciding whether you can sign up for the NHS organ register may require a lot more thought and reflection. But nevertheless, it's an illustration of how you can do an RCT pretty fast. If you can do it online and measure online. And the students really were signing up on the NHS organ transplant register when we did this study. So that's an example of an RCT which really gives the lie to the rumor that all ICTs need to be expensive and slow. Anyway, going back to how advice works. Well, obviously the output of the advice goes to a human user. Of course, there are a handful of AIs that don't have a human user, and those aren't part of this discussion. The human user then needs to take action based on that output of advice, and hopefully that will improve patient outcomes in some way. But what's going on inside the human? Well, first of all, they've got to perceive that there is advice there and make sense of it, understand it. And then I believe they have to trust it and register this is something which they should be taking on board in their decision making, and then use that advice to improve their decision. So it's really quite a complex chain, moving from the output to the outcome. And the reason that this is important is because I've seen people producing advice in bad formats. And you see this actually sometimes in EPRs particularly. A lot of the interfaces of EPRs are in poorly designed fonts, colors, all bold, poor contrast, small size of lattering, etc. So there are some issues just about text that can be a big problem. And we've got a table in our Lancet article 1998 showing how poor text formatting can affect readability. And if it's buried in the EPR interface, maybe consider a modal dialog box to try and bring it forward. Although we'll see in the case study that might not always be the right answer. If the advice only appears on request, we know from Van der Veld's systematic review and meta-regression, which was published in 2018, that if you do that, only appear on request, that's much less effective than producing the advice automatically. There may be circumstances in which you want to do that. moving away from text altogether, what about if you're producing a segmentation line on a mammogram to outline suspicious areas? Well, if that line is too thin or has poor contrast with the image, that's going to be a problem. You need to make it clearly visible and distinct from the image without hiding the rest of the image under the line. So there needs to be some transparency, but maybe there needs to be a wider line. Thinking about numbers, if a lot of decision support tools present risk figures as a percentage or a fraction, so 78% chance of a heart attack in the next 10 years, or 0.78, even worse. Well, Giga Renza and other psychologists have shown empirically that percentages and fractions, humans find those very difficult to interpret and incorporate in the decision making. Much better to use n out of 100, so 87 out of 100 or 870 out of 1,000. Or there are those caricature diagrams in which you have 100 or 1,000 faces, some of which are blacked out or red, or sad faces. So there are a number of alternative ways of communicating risk figures rather than using percentages or fractions. So perhaps we should revise that AI evaluation pipeline and insert a new stage in which, after the validation, we study and refine the impact of the advice or the output on users before carrying out the RCT. And ideally, we optimize the output to maximize its likely impact on users during the RCT. And that de-risks the RCT. And I'll give you some examples about what that means. But before we do that, it's also useful to register that if you talk to senior clinicians, which we did a survey of what they think about AI and clinical decision support. It's quite a small survey. They were responding on behalf of their professional societies. And we asked them what aspects of quality need to be evaluated. And of course, the first one that they said was impact of the advice on patient outcomes. These are in rank order of the kind of net benefit. The next one was the acceptability of the advice or risk estimate to clinicians, and then their ease of understanding and the impact of the advice on clinicians. So it does look as though clinical leaders believe that this is important as well. And of course, the accuracy of the advice was in, and other things. Interestingly, the cost effectiveness, over on the right-hand side of the table, cost effectiveness and impact on resource utilization was discouraged. They weren't really interested in that at all, as you can see. So what are the possible study designs that we could use to evaluate the impact of AI on users? Well, we could show the AI to people and say, well, what do you think? Will it change your decision? Really easy to carry out, but I believe it's really hard for users to predict their response to AI when it's actually in place. And there's even a worse problem, something called social response bias. When you do studies, people guess that what answer you want them to give you, and they want to please the researcher. So they will say, oh yes, Jeremy, it's terrific, I'll use it every time, even when I'm doubtful about the advice I'm getting. So you're not getting a really very good index of how useful the advice is by just simply asking people. An alternative, perhaps an extreme, would be to monitor real decisions during a baseline period and then implement the AI in a clinical setting, and then monitor the decisions afterwards. Well, that is a real world experiment. You'd actually find out how much users are responding to the advice. But the trouble is, that's a before after study, and it's really difficult to interpret these. There's things called secular trends. Things change over time, but there may be other events. For example, someone may have picked up on the poor decision making during the baseline period and have implemented an educational program, or just feeding back poor performance to the decision makers may have had an effect on them, let alone the AI. So it's quite hard in a before after study to know what really is the effect of the AI. And that's why we do randomized trials, obviously. That gives you a rigorous estimate of impact, but the AI needs to be ready for real world use. It needs to be integrated. We've said already they're hard to design, hard to run. And there's even something called the evaluation paradox, which I invented or discovered many years ago in the ACORN fields trial. When a nurse came to me during the middle of the field trial and said, this ACORN system, it seems really good, but why are you evaluating it? Are you saying that there's a problem with it? It makes me wonder whether I should be taking any notice of its advice or not. So almost by doing a randomized trial of a decision support system, you're advertising the fact you don't really know whether it's going to be useful or not. So you will underestimate the benefit of the system. Once you've done the trial and showed it's beneficial, it's more likely to be trusted and people more likely to incorporate it in the decision making. So I would suggest that at least the initial randomized trial of any decision support system is going to suffer from that evaluation paradox. So it may turn out to be a negative trial because people are over aware of the fact that you are trialing the system. You don't really know whether it's helpful or not. So what's the answer? The answer is a within subject pre-post psychological experiment. And I'll explain what I mean by that indigestible phrase in a minute. Relatively simple, quick, and cheap to run. And the benefit is you can not only find out whether people can find, interpret, and incorporate that advice into their decision making. You can also look at alternative advice formats. You could say, well, let's try this format and that format and compare them against no advice at all. It can't simulate the real world context of use. So it's an artificial setting. It's a laboratory setting, if you like. And you do need to assemble an adequate number of representative scenarios. And we'll see in a minute, that's not always straightforward. But nevertheless, it can give you an estimate of the impact of your advice on decision making. So let's go into a case study. So this is something which we did with NHS Blood and Transplant a few years ago. They were interested in the problem of inappropriate blood transfusion by junior doctors and huge variation in transfusion rates. And that has two risks. First of all, transfusion can cause risk to patients, but it also depletes scarce blood supplies. So they were very keen on using evidence-based guidelines, and they translated those into rules for an advisory app called Blood Choices. And they did an internal review and self-declared it as a type 1 device for CE marking. The app asks the doctor a few questions about the patient and then gives them advice based on national guidance. And there's an example of the kind of advice: transfusion generally not indicated. So the big question is this app accurate? First of all, have they correctly translated those guidance into their rules underlying the app? And then secondly, is it likely to make a difference? And this has been published by Amit Desai and others in transfusion medicine. So the first task was to assemble and test the scenarios for the evaluation study. And we worked with 24 hematologists who were external to the app development team. And we got them to assemble case scenarios of patients who would be eligible or not eligible for transfusion, but within the scope of the app. And they were both medical and surgical patients. And then we got at least 5 of the hematologists give their verdict on each scenario, whether the patient should or should not have a transfusion. And we also asked them for their certainty about that decision on a visual analog scale. And here are some sample scenarios. These are all surgical ones, very brief, as you can see, almost too concise perhaps. I'm honestly not sure what the verdict is for any of those. I'm afraid I'm too far away from this. So the first thing that we did is we asked for their verdicts, and we asked them to give a certainty score. And the mean certainty score across an average of 5 clinicians was varied from -100 to +100. These are the blue bars. And so it's 100% certain that patients shouldn't have a transfusion for that scenario. Some were really are not at all clear, 50-50, and then 100% certain that these patients should have a scenario. But there was a lot of disagreement. And this is the absolute value of the red lines, the absolute value of the difference between the maximum and minimum score. You can see in places there are some scenarios in which clearly one hematologist said yes, transfusion, and another hematologist said no, don't. It's probably easier to see on this graph. So the red dot here is the mean value by scenario. These are the different scenarios across here, and then the dotted line is the extremes, the maximum and the minimum. You can see there's really very good consensus on some of these, but terrible lack of consensus, huge disagreements on some on others. So we actually selected 5 of these with reasonably good with reasonably good agreement, which covered both don't transfuse, probably don't transfuse, probably transfuse, and do transfuse. So across the spectrum, and which also lay firmly within the scope of the app as developed. So that was an interesting lesson, that those scenarios, assembling those scenarios, took quite a bit of work, and we didn't end up with a great deal of consensus on them. So when we wanted to then move on to say, well, is the app safe and accurate using these scenarios? We excluded the scenarios of the largest disagreement, and that left 23 scenarios out of the original 28. And we discovered that the app agreed with the consultant consensus on 21 out of the 23. And there were 2 false positive errors. So the app was saying do transfuse when the guidelines said don't, and the consultant consensus said don't. Which in a way is probably the right way. If you're going to fail, then fail positive in this case. It's probably better to give a transfusion if you're in doubt than to not give a transfusion when somebody needs it. And those are the sensitivity and specificity figures. We then looked back to find out why the app was getting it wrong, and it turned out that there were some issues about the logic and the screen wording, so it wasn't obvious what was meant, so that was disambiguated, and it ended up as 100% accurate on those 23 scenarios. So that was all done with consultants, with experts, if you like. But we wanted then to find out what kind of impact will this app have on the intended users, the junior doctors. So we selected the 5 scenarios with the closest expert agreement, and I think I showed you those earlier. 4 was surgical, 1 was medical. And the experts were then asked to each recruit at least 1 junior doctor, preferably 4. We were aiming for 100 junior doctors. That was quite challenging. They used posters, they fingered people in their training sessions. I want you to come and do this experiment for us, etc. We still only recruited 26 doctors, and we had a prize draw to incentivize recruitment. Still only recruited 26 doctors. And then those doctors who were recruited, there was an online survey, and the doctors were sent a link to download the transfusion app. And what we did was the scenarios were presented in random order in a pre-post design. So pre-app, they read a scenario, one of the 5 scenarios, decided whether to transfuse or not, assigned that decision a certainty, and then went to the next scenario of the 5. And then they were given access to the app. And then the scenarios were rerun. They read the scenario. They entered. It was up to them to enter the data into the app. And then again, they answered the question, transfused or not, and gave a certainty until they'd completed all 5 scenarios, both in the pre-condition without the app and the post-condition after the app. And the interface that we provided them with really enforced this. They couldn't use the app in the 5 baseline scenarios. And we obviously recorded their answers. So what did we find? We asked the doctors, first of all, had they had sufficient transfusion test training, and more than half said yes. Surprisingly, only 81% were using clinical apps routinely. This was about 2020, 2019, I think it was just before the pandemic. And the bottom line accuracy is quite unimpressive, as you can see. They were quite reasonably accurate on the baseline, and it didn't really improve very much at all. It was only 5% better afterwards. So we were a bit puzzled by that, and we looked in detail by scenario their accuracy. And it turned out that one of the 5 scenarios, their accuracy was very high without the app, but it almost halved. In fact, it more than halved. It was a 50% drop when they used the app. And it turned out the app was giving the wrong advice, or the advice that it was giving was ambiguous and unclear. So that's a great example of automation bias, that the decision makers would have got the right answer, but the app gave them the wrong answer, and they followed the app. And this is well described. It started in the airline industry. There are cases, unfortunately, of planes crashing into mountains when the pilots can see the mountain, but they're relying on their altimeter and other instruments more than they're relying on their own human judgment. So that's automation bias. Um, if we exclude, this is post hoc analysis now, if we excluded scenario M15, the accuracy was 83% and went up to 96%, a 13% improvement, and that's statistically significant. Um, we also asked them for whether they would recommend the app to colleagues. 94% would. Did the advice, was the advice understandable? Would they use it in practice? Very positive. And they also asked them for other suggestions. Because this is one of the great things that you can do with this kind of study. When you've got people doing an experiment, you can ask them, you can talk to them, you can watch them using the decision support system as well, and get them to think aloud. So, what are the key lessons from this case study? You need a large number of experts to assemble a sufficiently wide range of scenarios. Getting consensus on gold standards can be challenging, and we found it very useful that we asked about the certainty as well as the decision itself. It was useful to have a large number of scenarios. Then we could actually pick what we thought initially was the best subset. In retrospect, M15 was not a great one to choose. It was also challenging to recruit the junior doctors, and some of those didn't actually complete the task. We only had partial data from some of those participants. Also, when users enter data and read the app output and interpret it, they may get different results from experts. And that's why we need to do this kind of study. It's because we don't know for sure how people will respond to these things. That's why we need to do this. And we've got some other useful advice about providing more detail on the patient scenarios. I showed you earlier, they were really just a couple of lines, very brief and abbreviated. And the less accurate decisions after using the app on scenario M15 showed clearly the benefits of this kind of app evaluation and led to changes in the app. Just imagine if we put this app out into real world use in a randomized trial, we would really have very red faces, feel very embarrassed about the fact that the app wasn't really giving the right advice on M15 to naive users. The sophisticated hematologists could understand what it meant and got the right answer, but not the naive users. So I don't know if it's helpful just to stop there briefly, or should I press on with another case study? Any questions or comments?
Let's see.
Thanks, Jeremy. Yeah, it's very insightful, especially because I do echo the fact that there needs to be like a further study in between before doing like a full rollout with the RCT. But I do need more clarity. Like, how do we do that further study if the users do not have like a prior exposure to the system? Are you suggesting like a simulation or a pilot study?
This is essentially using simulated cases. In that case, in that experiment, it was a real app that we developed, and it really was using the data that they put in. We thought it was important to get them to put in the data rather than say, well, this is what the app's advice is for scenario M6. We did get them to put the data in because that's part of the test. Really, can users abstract the correct data to put in? Can they answer the AI, the app's questions correctly? But in the next scenario, it was actually completely synthetic app. Both the user interface and the advice were all completely synthetic. We didn't actually build a decision support system at all. So this is one of the great things you can do with this kind of study design is you don't actually need to build a decision support system. You can simulate the whole thing.
Okay, awesome. I also wanted to circle back to the Children's Hospital where the use of this system increased risk. Do you
Yeah.
think it could be attributed to human factors like the users weren't properly trained and not really the effectiveness of the system?
It was a whole range of reasons, and Ross Koppel goes into some of this, but there were things like the system automatically locked the drugs trolley unless the nurses doing the dispensing were at the right location. And that meant if there was a crash call, for example, they couldn't unlock the drugs trolley
Oh,
um, to get the drugs that they needed. There were all sorts of socio-technical issues. It wasn't actually about the advice so much. from a system. But it's a wake-up call for why we need to do studies on systems, and not just assume that because we've done a great job of our requirements analysis and used appropriate software engineering techniques, it's all going to work well. Unfortunately, particularly in healthcare, the human world is too complex to be able to predict what the impact will be.
Right, right. Thanks for that. Also, for the transfusion experiment, you recruited some experts to kind of give some recommendations prior to exposure to the app. Did you consider the experience of these experts to be able to
We
predict?
did.
Okay.
One of the things we wanted to exclude the real experts, if you like, the tertiary referral center experts who'd actually designed and developed the app with some computer scientists, the experts from NHS blood transfusion, blood and transplant. So we didn't want to use them. We deliberately went to the next level, if you like, and contacted members of the British Hematological Association who had a specialty in blood transfusion. So they were pretty good experts, actually, typical of the kind of people you find around teaching hospitals and district general hospitals in the hematology specialty.
Awesome. Final question. So for the results, one of the findings using the app, you saw that there was just a minimal impact of the app in prediction for
Yeah.
transfusion. Um, do you think over time, if clinicians were to rely on the app, it would lead to them solely relying on the app as opposed to using their judgment? In that case, would you recommend not implementing or adopting the apps in clinical settings and just suggesting that clinicians use their own judgment since they've gone through the training and they're experienced?
Um, yes and no. Where the clinician has those skills, then yes. But the trouble is that there are a lot of junior doctors around the UK NHS who don't have that training experience. In fact, our users were relatively sophisticated. They've been recruited by the haematologists, and perhaps there was a little bit of competition. The haematologists wanted to show off their staff and how good they were. So the baseline performance was actually much higher than we expected. But it was only 5 scenarios. We wanted and intended to use 15 or 20 of those scenarios, but unfortunately, the logistics of recruiting these junior doctors and capturing them for sufficient time, for 30, 45 minutes to do the full scale experiment, it just didn't work out. So we did a pilot, and it turned out that they just didn't get, the 2 or 3 who did the pilot just didn't get through the scenarios. So we cut it radically down to only 5. So we weren't the precision of that experiment was really quite low. We didn't have sufficient sample size.
Okay. Yeah,
Thank
because
you, Marianne. Good
Any other?
question.
quick one. Yeah, I'm very concerned about the junior physicians. Like, how soon should they be exposed to using this app? Should it be right after graduation? Because we need them to be willing
That was
to.
the intention. Yes, it was to fill in for the fact they didn't have much training or experience on which patients needed transfusion. There's
Right.
quite a lot of concern. And I didn't present the data, but there was clear evidence that the baseline performance was lower in the more junior clinicians, and there was a greater benefit from the app in those junior physicians than in the more senior group.
Mm.
Um, we actually recruited some more senior people. We didn't really want the more senior people. These were specialist registrars rather than F1, F2 doctors. But even so, they still made mistakes.
Awesome. Great study. Thank you.
Thank you, Marianne. You don't ask one question, you usually ask 5.
Any other burning
They
questions,
were
or should
good
we move on?
questions. Thank you. Anyone else?
And there's something appearing in the
Chat. Is it?
chat. I'll look at that later. Let me get
Yeah.
my slides up again.
Okay. Thank you.
Could be that one. Right, now I just need to find where to resume. Sorry, I didn't expect to go back to the beginning. Why has it done that? That's really miserable of it. Right, okay. So here is a different, a second case study. And this one is a little bit more complicated, as I mentioned. It's about comparing two alternative advice formats, and it's in the context of prescribing and e-prescribing. The background is that in the UK, GPs often turn off their prescribing alert systems because they have modal dialogue boxes which are too intrusive and interrupt the consultation. In addition, there's psychological evidence that interruptions worsen decision making. So avoiding interruptions surely is a good thing to do. So our question was, maybe we could design a less intrusive kind of alert, which was also still effective and more acceptable to those doctors. So what we did was another similar pre-post experiment with 24 junior doctors, not GPs this time, hospital doctors, and they each viewed 30 prescribing scenarios which were presented in a random order in one of three conditions: with no alert at all, or an alert presented as a modal dialogue box, an interruptive alert, or actually on the e-prescribing interface. And I've got example screenshots showing what these look like. And both the e-prescribing system and the prescribing alert text were all simulated. We didn't actually construct an e-prescribing decision support system for this. And this was carried out by quite a junior doctor who'd got a first degree in computing, actually, and published in JAMIA. So here are the screens. This is an interruptive alert. And this is typical of the format that you get on e-prescribing systems. Plasma levels of digoxin can be doubled by amiodarone. Recommend halving the digoxin dose. I mean, it requires you, it's modal. You have to press that OK box to get rid of it. The alternative format was non-interruptive. It's exactly the same text, but it's appearing, as you can see here, in the e-prescribing screen. So it appears, but you don't have to do anything to get rid of that. It's not interrupting your prescribing. So we did this randomized pre-post study in which the doctors received either no alerts, non-interruptive alerts, or interruptive alerts. And you can see here the median error rate with no alerts was, this was out of 20 trials. The median error rate for no alerts was 5 out of 20, then it went out to 2 out of 20 for non-interruptive alerts, and 1 out of 20 for interruptive alerts. But perhaps the most interesting figures are the number of safe doctors. And I can't remember the exact definition of that, but it was doctors making 3 or fewer errors out of the 20 scenarios. And you can see for no alerts, there was almost no safe doctors. For non-interruptive, half the doctors were safe. For interruptive alerts, 19 out of 20 doctors were safe by that definition. And other ways of looking at this, the interruptive alert was 10 times more effective than no alert at all. That you can see that's highly significant. But interestingly, the non-interruptive alert was 5 times as effective as no alert. So really a very useful effect. And they were also much more acceptable. We did some interviews with the clinicians after the experiment, and they at a focus group, and they said, well, the non-interruptive alerts, sometimes I missed them. The full paper's got some of the quotes from the ethnographic study that we did, but they were just much more acceptable than interruptive alerts. So we then went on, perhaps a bit rashly, to model what would be the potential impact of non-interruptive alerts if they were implemented across the whole of the special health authority that I was part of then, which had a population of, as you can see, 15 million. And we made all sorts of assumptions here, some of which you might dispute, but some of these are indeed regular figures. I think that comes from the same BMJ article, the rates of ADRs, adverse drug events, etc. This is perhaps a bit more conjecture. GP prescribing is responsible for about 50% of adverse drug emissions, and about 3/4 of GPs turn off their interruptive alert system. And that was actually based on talking to GPs, and most of them say, oh, it's impossible, I just can't work with it on. And that non-interruptive alerts reduce prescribing errors to 1/5, and that's from our results. So you can see modeling that, and they've got a spreadsheet model. The current position was nearly 65,000 avoidable ADR emissions, and with non-interruptive alerts, that would drop considerably, not to nothing, but it would drop considerably by nearly 20,000. What about the death rate? Potentially this could save 450 deaths, and it certainly would avoid a lot of bed nights. The ADR admissions last a median of 8 nights. They're very long and complex to sort out, often occur in elder people with polypharmacy. So we wouldn't have been able to do that if we hadn't done that study to find out the likely benefit of non-interruptive alerts. So that's an example of the benefit of doing this kind of study. And we were able then to compare 2 different alert formats, both of which in fact were simulated. So some conclusions. Of course, validation studies are needed, but we need to treat the AI as a decision maker. And that means doing studies on whether and how much it affects the users. RCTs are necessary, but they're expensive, and they do run the risk of negative results because just some little bit about the user interface of the advice form wasn't quite right. And just imagine how you'd feel if you'd run a complex randomized trial, it was negative, and then you'd done an accompanying process evaluation which demonstrated that there was a really good reason why people weren't responding, and if only you'd done X, it would have been a highly effective system. So before RCTs, we need to check if users can find the advice, understand it, and are willing to act on it, or perhaps if a different format would have more benefit. And these are psychological or so-called intervention modeling experiments. They do need to be designed carefully, though, to answer the questions. And they can act as a bridge between the validation of the algorithm and randomized trials and help de-risk the RCTs that we need to carry out. This really, I suppose, is a good example of what I call good evaluation practice. Know why you're evaluating, what questions you've got, and the level of evidence. Design your study with enough participants, not always easy, with the right intervention and control and validated outcome measures. Check for biases and confounders, and think about how you will overcome those. And particularly if the study's going to be negative, how will you learn something? Run the study and report your results, even if negative. And this is from Elizabeth Murray's article in American Journal of Preventive Medicine. And there's our 3rd edition of our textbook, finally out a couple of years ago. That is my conclusion. And I'd be really interested in your comments and thoughts.
Thank you very much, Jeremy, for a very, very interesting lens on evaluations. So